UAB MedCast is an ongoing medical education podcast. The UAB Division of Continuing Education designates that each episode of this enduring material is worth a maximum of 0.25 AMA PRA Category 1 credit. To collect credit, please visit uabmedicine.org/medcast and complete the episode's post-test.
Welcome to UAB MedCast, a continuing education podcast for medical professionals. Bringing knowledge to your world. Here's Melanie Cole.
Welcome to UAB MedCast. I'm Melanie Cole, and I invite you to listen as we examine the Urology and Radiology collaborate on alternative image-guided prostate biopsy approaches. Joining me in this panel discussion today are Dr. Sam Galgano. He's the section chief of abdominal imaging in the Department of Radiology and an assistant professor at UAB Medicine. And Dr. Sarush Reis-Barami. He's an associate professor and a urologist at UAB Medicine. Gentlemen, I'm so glad to have you with us today. Dr. Reis-Barami, I'd like to start with you. Tell us a little bit about what you've been seeing in the trends with prostate cancer today and how treatment has evolved in the last 10 years or so.
Yeah, thanks, Melanie, for hosting this. I absolutely passionate about this topic and want to talk about how prostate cancer, again, is recognized as the number one diagnosed solid organ cancer in American men. So a huge public health dilemma in the field of cancer. And really the treatment approaches are really contingent on appropriate risk stratification and early detection of these cancers to provide men the full gamut of options in terms of management, whether that be through active surveillance or intensive monitoring versus various early curative treatments, hopefully for early detected, early stage cancers. And that's one of our goals, is to provide good screening and early detection with proper risk stratification to give men all the different options for management of this public health dilemma and this common cancer.
Well, thank you for that. So, Dr. Galgano, I'd love for you to tell us about the Urology and Radiology collaborate on alternative image-guided prostate biopsy approaches at UAB Medicine. How did this come about? Tell us about it.
Thank you, Melanie, for having us. The departments of radiology and urology at UAB have a long history of collaboration that predates even me as a resident. And so as we go forward, we collaborate in research and we collaborate in patient care with these alternative approaches to prostate biopsies being the newest offering that we have in our sort of armamentarium of things to offer patients for prostate cancer screening and then ultimately prostate cancer treatment and management of their disease. The departments of urology and radiology collaborate frequently to manage image-guided biopsies of various different organs outside of the prostate gland that routinely have the kidneys, adrenal glands, and pelvic lymph nodes typically, and the prostate biopsies of the prostate have traditionally been performed almost exclusively by urologists, with transrectal ultrasound-guided biopsies being suitable in the vast majority of patients and with great success. There is a subset of patients that we have encountered here at UAB who, through various other medical conditions they may have, for one reason or another, are not able to undergo or tolerate a transrectal ultrasound, either due to prior surgery with altered anatomy and or areas of narrowing in their anus and rectum that could prohibit the passage of the transrectal ultrasound probe. So these men are typically unable to undergo transrectal ultrasound-guided biopsy, and they were left in a situation in which they didn't really have a mechanism to undergo a screening prostate biopsy to evaluate for prostate cancer. And so the collaboration that Dr. Reis-Barami and myself have developed is to find alternate ways to gain access to the prostate gland to allow for systematic needle biopsies for prostate cancer screening.
And I would just dovetail with what Sam has mentioned, that it is not uncommon that patients have pathologies or diagnoses in the GI tract. Specifically, we've encountered patients that have had anal stricture disease or prior history of hemorrhoid treatment that causes scar tissue in the area of their anal verge, which cannot, again, comfortably or even physically, in some cases, accommodate a transrectal ultrasound probe passage into the rectal vault to allow for examination of the prostate and guidance of biopsy needles for prostate tissue sampling. And these patients, as well as some who have undergone colon and rectal surgery, perhaps for prior diverticular disease or more commonly for colon and rectal cancers, may have post-surgical absence of anus or distal rectum So those patients are unable to undergo any ultrasound exam through the rectal vault as well. And oftentimes these patients are simply screened with PSA screening, obviously not able to undergo digital rectal examinations by their primary providers or their urologist. And they're left in a situation where PSA may become suspicious for potentially harboring prostate cancer, but they don't have a suitable way to undergo a comfortable, accessible prostate biopsy for the next step in screening. And so they're left in a bind, as was mentioned, and we have developed an opportunity for these patients to undergo the next step in standard screening to determine whether or not there's prostate cancer and hopefully render an earlier diagnosis in these patients rather than simply using the nonspecific PSA test for follow-ups.
So then speak just a little bit, Dr. Galgano, about the patients that you are seeing. How have been your outcomes? How's it working out for you and when you two are working together this way?
The outcomes have been very successful thus far. We've been successful in every patient. We've had this scenario come up and undergone this sort of collaborative approach. In the beginning, like any new venture, it was a bit of unfamiliar territory, particularly for radiologists who traditionally do not perform this procedure. But I think it's the strength of the collaboration that we have between the urologists and our department in radiology that we were able to, for the first couple of patients, go side by side and work closely together, drawing on my experience with, percutaneous ultrasound-guided procedures that we traditionally do every day on other organs of the body, and then the urologist's experience with biopsying the prostate gland, again, typically via a transrectal approach, but their comfort in sort of the anatomy and surrounding areas that would traditionally be less familiar to a radiologist performing these procedures. As we've done more and more, we've become more efficient, we've become more streamlined, and we've even opened it up potentially to beyond ultrasound, expanding it to CT, which we have now done.
So just to add to Dr. Galgano's mentioning there, I would say that patients that we have treated have been patients that have had prior rectal cancers, colon and rectal cancers that have led to a closure of their anus and perineal skin. In addition to not having an anus and rectum to allow for transrectal ultrasound, these patients who have undergone prior surgery in that area for their colon and rectal cancers also have a significant amount of scar tissue in that perineal and deep pelvic region. So we have worked together to overcome that by performing ultrasound-guided biopsies through the perineum. So the surface of probes are used by examining ultrasound through the skin of the deep pelvis and perineum, and then conducting percutaneous approach biopsies, like Dr. Galgano mentioned, through the perineal skin and scar tissues in these postoperative cases to access the prostate gland safely. These patients have minimal blood loss or risk of bleeding, no more than the typical office procedure in patients who can undergo the transrectal approach. And additionally, these patients have actually been reported to have lower risk of infection since there's no violation through the rectal wall in these patients, and everything is through a sterilized surface skin approach. And so potentially a benefit of this in this subset of patients may actually be a diminished risk of post-procedural infections even.
Well, then, Dr. Ray Sperami, tell us why there are only a select few urologists in the United States trained to do what you're discussing today. Why is that?
Part of it is the need. Obviously, it's a very small proportion of the population of men who may have these anatomic differences or disease processes or history of surgeries that preclude them from undergoing the standard approach to prostate biopsy as part of their cancer screening. So I think the need for it is limited compared to most men who can undergo transrectal ultrasound biopsies, either through a transrectal approach or transperineal needle sample approach. But because of that, these cases often go with potentially later biopsy samplings or later diagnoses. And what we wanted to establish a very streamlined yet multidisciplinary approach to providing optimal early detection and opportunities for early biopsies in this patient population for the region that we serve here at UAB, again, treating patients from not just the Birmingham area and the state of Alabama as a whole, but even surrounding states where we have referrals coming from many urologists that do not offer these alternative approaches to biopsy sampling.
Such an interesting topic. And Dr. Galgano, I'd like to give you each a chance for final thoughts. What would you like other providers to know about what's exciting in your field? What's coming up in the next 5 years or so as far as imaging and biopsy techniques? What do you see happening on the horizon?
I would say from a radiology standpoint and a collaborative standpoint, one of the most notable things that we are on track to bring on board at UAB is an interventional MRI suite. And that is a MRI suite in which procedures of varying types can be performed. And that's slated to come in the near future and be installed and be up for clinical practice. The prostate in general, in this setting of patients that we're talking about and other patients, is prime for MR-guided interventions where you can visualize lesions in the prostate that you would otherwise be challenged to or be impossible to see on ultrasound or CT, and allow for potentially targeted biopsies similar to the transrectal ultrasound MR fusion software that's utilized in the urology clinics. So it's an area of potential collaboration and a number of different applications in the future.
Dr. Race Barami, what's your vision for this program and this collaborate? How do you see that this care model is going to improve the way patients are receiving their care, and this procedure that we're discussing and the service is as streamlined as possible? What would you like other providers to know about how you see this and when they should refer their patients to UAB Medicine?
Absolutely. Thanks, Melanie. And one of the things I would really like to emphasize is our multidisciplinary approach. I think since my joining the faculty at UAB Medicine and helping to establish the UAB program for personalized prostate cancer care, the big goal of that has always been a multidisciplinary approach and bringing expertise from different fields of training, like our radiologists, our urologists, in certain cases our pathologists, our radiation oncologists, all to put our minds together for a multidisciplinary panel of experts to have multiple minds, areas of expertise and training coming together for guiding detection and treatment of cancers that patients are diagnosed with and suffering from. And this is just one example where we have found a population of patients that we're not finding the providers and the care that would be comfortable with performing biopsies and performing the next level of care for their prostate cancer diagnoses. And thanks to Dr. Galgano and his support in building this, we've come together, and the referrals that have come to UAB with these anatomic differences have really benefited from this collaborative multidisciplinary approach, I think.
Thank you both so much for joining us and telling us about this collaborate on alternative prostate cancer screening approaches. It's really very fascinating. Thank you again. And a community physician can refer a patient to UAB Medicine by calling the MIST line at 1-800-UAB-MIST. That concludes this episode of UAB MedCast. For more information on resources available at UAB Medicine, please visit our website at uabmedicine.org/physician. Please also remember to subscribe, rate, and review this podcast and all the other UAB Medicine podcasts. I'm Melanie Cole.